Ladies and gentlemen, Dr. Nadir Ali.
So the first thing I would like to do is to give a shout out to Brian Williamson and Jimmy Moore for putting this together. Thank you. I'd like to say that Jimmy does more for the health and well-being of society in general than I do as a cardiologist. I have a bit of a home court advantage. I'm from Houston, Texas. Plus, we got flooded a little bit. So I think that I'll have your sympathies. And I'm very passionate about this area. So being an Indian, when you are passionate about something, you speak very fast. But I'm going to try to slow down for the important parts. So I'd like to start out with an anecdote. This is one of my patients who came in not too long ago. And for the last 10 years, he's been treated for diabetes with different drugs. One of them is Actos, which works on a receptor in the brain and increases feeding behavior. So it increases insulin resistance. Another is glipizide, which makes the pancreas that's already working hard in a diabetic, because type 2 diabetics have high insulin levels, not low insulin levels. And it's saying, hey, you're not working hard enough, let's make it work harder. And then when these two drugs didn't work, they started giving him large amounts of insulin. And what large amounts of insulin do is increase feeding behavior. So the healthcare professionals, I think, treat diabetes completely the wrong way, because they do everything to reduce blood sugar while increasing insulin resistance. And when your insulin levels go up, your blood pressure goes up, because nitric oxide levels that the endothelium makes go down. And in order to treat blood pressure, they started giving him beta blockers. Now, what beta blockers do is that they slow somebody down. They make them inactive. And when his cholesterol became maladapted, they started giving him statins. And as a result of that, he had cognition issues, erectile dysfunction, and I'll touch on some of these aspects a little bit later. So go ahead. I think that doesn't want to work. Can you go next slide? Matt? Okay, thank you. Why don't you start playing this? So this patient came into the hospital having a myocardial infarction. And this is an angiogram of him. You see that that's the left anterior descending so-called widowmaker, and it has a tight blockage. And Ivor talked a lot about coronary calcification. He has got coronary calcification also. This will play a couple of times so that you get an idea as to where the stenosis is, which is the blockage, and where the calcium is. Next slide. So for the last 25 years, I've been a cath lab rat. I'm one of the best interventionalists that I know of. You guys are supposed to, okay. And I said that, hey, listen, I hate being in the office. I do not like treating patients in the office. So if you can see out here while this is playing, I fixed that person because that stenosis is no longer there. It continues to show the coronary calcification. So let's go to the next slide. While that is coming up, what I want to tell you is that I hated being in the office. And the reason is because I said, I'll fix them in the cath lab, because none of the things that we do, none of the medications that we give really work, and I don't want to spend any time. But back in 2014, I'm a cyclist, and I needed to lose roughly about 20 pounds. And some of you who know me know that I'm a pretty determined guy. And I tried my best to lose those weight, and I found myself to be morally corrupt. Or was I really morally corrupt? I was just following the standard American diet. And then I read a story about Chris Froome. And those of you who are cyclists out here can understand about the Pinarello dogma. And he went on a low-carb diet, and he went down from 75 to 60 kilograms. And I was also watching one morning a podcast by Zishan Arian. He's a sports medicine doctor in Australia. And you can see that he was pretty metabolic syndrome-like obese, and he got ripped and muscular. And you see that he also lost his body hair. That is not from a low-carb diet. So I started wondering, as a cardiologist, I always used to think about LDL as atherogenic, something that is causing buildup of atherogenic cholesterol-laden material that is blocking blood vessels. But really, I think we need to rethink what our cholesterol is all about. Because LDL has many functions, and I have elucidated some of them out here. And thanks to the work of Dave Feldman, who you will hear, I think, tomorrow, the seminal discovery that he has shown is that our LDL, which starts out as a VLDL, is primarily an energy delivery system for us. It also has antioxidant functions. It supplies CoQ10, which is an important cofactor for your muscles to be able to use energy. A lot of fat-soluble vitamins are carried in LDL. Its capability extends to neutralizing pathogens. It's highly involved in malignancy and apoptosis, and I'll explain that a little bit later. And then steroid hormone synthesis and neurotransmitters. So what you see out here is that the LDL starts its life as a VLDL. It's an endogenous lipoprotein pathway. So in order for me to distill this down a little bit more, what I'd like to tell you is that both triglycerides and cholesterol are fatty molecules. They don't dissolve in blood. Our blood is aqueous or watery. So in order to carry this, the LDL is packaged into submarines or cargo ships. And so what the LDL has is cholesterol and triglycerides packed into it as cargo, but in addition has other things, the fat-soluble vitamins that I talked about. And the LDL goes about in the circulation, and in the presence of a lipoprotein, which is a signaling molecule that is on the surface of the LDL, along with a protein that is present in different cells on the endothelium, it starts delivering energy. It starts delivering triglycerides. So it's delivering triglycerides to the fat cells, as you can see there, to the myocyte, which is the heart muscle cell, and to the skeletal muscle cell. And what I'd like to tell you here is that insulin modulates this. Can you click next? Insulin modulates this up and down. I guess. Okay, so presence of low insulin levels make your triglycerides shunt a little bit more towards the muscle cells. The presence of high insulin levels make the triglycerides shunt towards the fat cells, something like Ivor talked about. All right. Now, what I'd like to tell you is that in the presence of things that we do, the ketogenic community does, which is fasting, low carb, and exercise, the triglycerides are being used predominantly by the muscle cells. And in order for the triglycerides to be used predominantly by the muscle cells, you got to produce more of these VLDL molecules. This seminal discovery that our body needs to traffic more VLDL was not really apparent to lipidologists who have studied this for about 70 years until a software engineer like Ivor, Dave Feldman, comes out and talks about the trafficking of VLDL molecules in response to energy needs. So that's what it is trying to show you in the next slide, that we traffic more VLDL particles as ketogenic people. All right. I'm going to skip that. Next. Just go back one. My patient had erectile dysfunction. And I want to make sure that I explain to you that the reason for his erectile dysfunction was statins, because one of the key factors is that LDL supplies cholesterol to the gonads. The gonads cannot make any cholesterol by themselves. So the sharp increase in erectile dysfunction is not probably just because there are drugs to sell, but because such large percentage of our population is statinated. Okay, next slide, please. So I'd like to kind of take you through some of my patients to illustrate some key points. So this is a 77-year-old man, and he has had multiple health problems from 2008 to 2014. He's had bypass surgery, he's had heart attacks, he's got stents, he's a diabetic, he's obese, and this is salt of earth man. He follows all the significant advice that physicians give him. And despite all of this, he became heavy and had all these issues. So back in December of 2014, he attended one of my nutritional seminars and decided to go ketogenic, and you can see that he started losing weight. Go next slide. At about the same time, he had his blood work done just before he went on this program by his primary physician, and you see out there that his triglycerides are high, his LDL cholesterol on statins is dramatically low, it's 63. And you see the handwriting of the primary care physician that I stuck up there. He was asked to go on a low-fat diet, which he was already doing. Okay, go to the next slide. This is his hemoglobin A1C, 7.1. So after doing what he felt was right for him, which is the ketogenic diet, this is what happened to him. Next slide. And you can see that his hemoglobin A1C, without any intervention of medications, came down from 7.9 to around 5. His insulin levels, his fasting insulin levels and HOMA scores significantly dropped, and he became less inflamed, as you can see, based on CRPs. Next slide. All right, these are his cholesterol numbers when he's not taking statins on a ketogenic diet, which is low carb, high fat, along with fasting. And you can see that his LDL is high. His HDL cholesterol has gone up, and I've got a few vignettes to give you about the HDL cholesterol down the road. And you see that he changed the size of his LDL, which is considered to be the atherogenic small particles to the large Patinae or large fluffy particles. Next slide. So his healthcare worker, his primary care physician, wants him back on a statin. And I want to lead you into this trial, which is called the Fourier trial, which was published back in April. And I gave a presentation about this to my medical staff. What you see out there is 28,000 patients being enrolled in this clinical trial. And 28,000 patients followed for 2 years. The reduction in cholesterol was dramatic. It went down from 90 milligrams, which was the Lipitor-only arm, to about 30 milligrams. So you cannot have LDL levels below that. Below that, it would become 0. So if you take 28,000 patients and you give them a drug that dramatically drops their LDL, and if LDL is such an atherogenic molecule, none of these people should die of heart disease. And what you find is that there were more deaths in the treatment group than in the control group. So I think at this point, it's time to quit saying that dropping LDL really helps. Go next slide. Now this is another man. This is another big discovery from the low-carb, high-fat community, which is lean mass hyperresponders. He's a 64-year-old man who had a myocardial infarction, got a stent in. At the time he had the stent, he was already on a statin. His LDL levels were about 90 milligrams per deciliter. So after he got a statin, he came to me because he heard from word of mouth, because he was having statin-induced side effects, and he had taken it for 10 years, and it didn't help him avoid heart disease. So when he came, he went on a low-carb, high-fat diet. He dropped his BMI, he dropped his weight, despite the fact that he was lean mass. And you can see that his LDL cholesterol jumped to 275. And he was about 90 milligrams on a statin. This is 275 with a change in diet. His CRPs fell. His hemoglobin A1C, which was in pre-diabetic range, went down into the non-diabetic range. And his HOMA-IR scores and his fasting insulins were excellent. So that's a lead-in to the study that was done in 1999, and it ties into Feldman's work to some degree, which is that fasting is a very good way of increasing your LDL cholesterol. Our body homeostatically regulates the amount of energy we need by putting out the LDL cholesterol so that we can use it for energy. So what you find here is that there were about 14 individuals that this person made them fast for 7 whole days. So for 7 days, they did a water fast. They didn't eat anything. And what you find here is that the cholesterol levels went up from 189 to 260. The LDL had about a 69% increase from 112 to 190. And what you find is that insulin-like growth factor went down quite dramatically, which is shown on the other axis. So next slide. All right, this patient has also taught me a lot. This is Sarah. She's a 50-year-old Oriental lady. She was referred because she had very high LDL levels. Her doctor, her endocrinologist, wanted her to take statins. And she didn't because she had heard that statins are not good for her. She was normal body weight, normal BMI. She was diagnosed as a type 2 diabetic, given all kinds of oral hypoglycemic medications. And I think she was misdiagnosed. Like Ivor showed, she's either a Kraft 5 or a type 1 diabetic. And I can get into the weeds of that a little bit later if you would like. Now, I referred her to the podcasts of Jason Fung and Troy Stapleton. Stapleton has a beautiful talk, and anybody who's a type 2 or a type 1 diabetic should really watch that. So she's LDL 188, pattern A, and her HDL is 48, and I put a little asterisk out there to kind of talk about that. And the CRP was 0.2. Her hemoglobin A1C fell to 5.5, and she feels better than ever. Next slide. Okay, so I hope you can see this slide, because this is Sarah's own diagram. She did this for me. And what you see out here is that at the time of diagnosis, her hemoglobin A1C on the top left was very high. And she went through many experiments. She went through a plant-based diet, a whole food diet, a standard American diet, and her hemoglobin A1Cs remained high until she went ketogenic. And you see with ketogenic diet, along with fasting that she started with Jason Fung's program, her hemoglobin A1C came down quite a bit. And I can tell you, patients like these have taught me so much more than I have learned from reading and learning from my colleagues. Next slide. So I told you that I'll talk a little bit about, is that clock going up? Okay, yeah. I said I'll talk a little bit about HDL. Now, HDL is, and I'm not sure, the reason I'm saying this is because I'm not sure having high HDL is always the right thing to have. Because HDL is made as a nascent protein in the liver and intestines, which is called the discoid HDL. Then it picks up cholesterol from macrophages through different proteins. And then it starts dropping off the cholesterol that it has picked up into the LDL and VLDL molecules. This is called the CETP inhibitors. Cholesterol acyl transfer protein, cholesterol ester transfer protein. Next slide. So I want to show you this Illuminate trial, and I'd like to spend a little minute on it because Illuminate really illuminates a lot about the cholesterol and the lipoprotein metabolism. They took 15,000 patients, and the conventional wisdom is that having low LDLs is very good, and having high HDLs is very good. So this is what they achieved, and if I had a pointer and I can take you to the left portion of the slide, and I can show you that the LDL levels dropped from 79 down to the low 50s or mid 50s, and the HDL levels went from 50s to about high 70s. So this would be the perfect engineering that somebody could have in terms of your lipoprotein. right? You have low LDL and high HDL. The control group, there was no change. The LDL was high, the HDL was low. Next slide. Let's see what happened. What happened is that, and I would apologize if you can't read it out there, but what you can see is that there was an increase in cardiovascular death, there was an increase in cancer, there was an increase in all-cause mortality. Because I think that the HDL molecule is doing a fundamental role, and the fundamental role of the HDL molecule is to transfer the cholesterol to the LDL, and LDL is doing several processes that we will talk about in the homeostatic regulation of LDL in a bit. Next slide. Next slide. All right. I'm going to take you through this lady. She's an Oriental 69-year-old lady. She was referred to me for chest pain. She had a positive stress test. For 10 years, she's been treated for high cholesterol. She's taking a statin. And I think her chest pain was coming from the statins. She's got neurocognitive issues, and I'll go through that in a little bit. Her husband says she goes out, and she's driving, and she forgets where she is, cannot make it back home occasionally, not all the time. Her BMI was okay. Her HDL levels were good. Her LDL levels were low on statins. She had a slightly high hemoglobin A1C. No insulin levels were done. She was set up for a coronary angiogram. Let's play that next. All right. So the reason I put this slide up is that about 25% of our cholesterol is in the brain. The cholesterol is an integral part of neurotransmitters because the structure of the neurotransmitters is designed in such a way that if there is no cholesterol, the neurotransmitters don't function. So people who have low cholesterol and people who are on statins have a higher incidence of depression, anxiety, cognitive issues. Next slide, please. So Ivor talked a lot about calcium. Let's play it, please. So what you can see out here is that this coronary calcification is almost all adventitial. That means it's on the outside of the vessel wall. It's not on the inside of the vessel wall. And play the next one, and it'll be apparent a little bit more because that gives you an orthogonal, the opposite angle. And you can see there is a speck of calcium that I have outlined with an arrow. And as you play it, you see that the calcium is on the outside because the lumen is all intact. So I think calcium, much like LDL, is out there to repair tissue, not really the culprit, and we need to understand calcium metabolism better also. I'm not disputing that presence of calcium is a very strong predictor of having vascular disease. Okay, next slide. So I wanted to talk about the homeostatic regulation of LDL, and LDL responds to infections, inflammations. I think it's responds to apoptosis. But I think, next slide, please. But the seminal finding is that I hope all lipidologists, cardiologists, physicians know is that LDL is used as a trafficking molecule to supply energy to our cells. And next slide. So when you do a low-carb, high-fat diet, when you do fasting, when you do exercise, by design, your LDL is going to go up. You know, in my clinical practice, and I've been doing it for 3 years, I would rarely find a person in whom the LDL remains same or goes down if they have been following it properly and you have given it enough time. The HDL story is a little bit funky, and we talked about that a little bit. The triglycerides always go down. Next slide. And let's go next. Because I'd like to... that clock is going up, Brian. So I got 7 minutes. Wow. Oh, I have got lots of time. I think I must be speaking very fast, my Indian mentality. The reason I put this up is that this is what I talk to my patients about. I talk about low-carb, high-fat diet, fasting, exercise. I believe that you should get vitamin D from sunshine, not from pills, but pills is a reasonable replacement. We talk about K2, which is the calcium paradox. But always I try to tell my patients that having high LDL, if everything else is going right, is a matter to celebrate, not to mourn. And the homeostatic regulation of LDL requires that we will be trafficking more LDL. With fasting, we will be dropping insulin-like growth factor, which will increase your LDL. With apoptosis, you may need LDL to clear up the stuff. And is it detrimental? Is high LDL detrimental? Because the conventional wisdom is that when you have high LDL, it results in atherogenesis. And I'm not so sure that I buy into that argument quite like Dr. Dayspring and Peter Attia tell us about. Because I think when you compare it to drug therapy is not something that improves the homeostasis in the right way and really leads to maladaptations in LDL metabolism, and it leads to insulin resistance. So let's skip forward for a couple of slides, please. I know, go back one, because that's my punchline, right? I think that we as clinicians, go back, please. You're taking away my punchline. We as clinicians have abdicated our clinical responsibility to key opinion leaders, big pharma, the food industry, and various medical societies, like leaving the church. Like somebody told me, I think Mark Crisella told me that I need to leave the church, which is the AHA and ACC. And we've really relinquished our clinical thinking capabilities. Next slide. And let's go one more forward. So I think that consequently, and I agree with Jimmy, I'm glad that you don't go to healthcare professionals. We as healthcare providers have to accept responsibility that we are the single biggest cause of morbidity and mortality in this country, and by extension to the rest of the world. So I'll stop here, and boy, was I too excited and that's why it's going so fast? I've got 3.5 minutes for questions if anybody wants to ask me.
Hi, Nadir. Dave Feldman. How are you?
Dave, shout out to you. I finally see you in person.
Likewise. I can't wait to chat with you a little bit later. I just wanted to specifically thank you for helping to move this model of energy delivery by LDL particles forward. It's way overdue. Thank you so much, because we need more medical professionals, not just us lowly engineers, to make it clear to everybody, especially everybody in this audience, everybody in the world who's taking on a fat-adapted diet, that it's not just about the ketones. It's about the triglycerides that are brought in LDL particles. It's about the non-esterified fatty acids that come from the adipose tissue. We're powered by fat as much as we're powered by the ketones that are brought about by breaking down fat.
I can just give a little addition to that, just I learned from you, is that ketones probably supply only about 15% of the energy and are reserved for the brain and other tissues that cannot metabolize triglycerides.
That's right.
The majority of our energy is coming from triglycerides, especially if you're in a ketogenic kind of phase or a fasting phase, right?
Yes.
Hi, I'm Gail Pasley. I have all good numbers on all my LDLs and HDLs, but my heart doctor still put me on a statin. How do I get him to take me off of it? He says it's because I've had bypass surgery and we don't want the numbers to go high, so with the statin we'll keep it low.
Yeah, unfortunately, two people can look at the same data and come up with totally different answers. The studies in women show that women, whether they have had bypass surgery, stents, the degree of mortality benefit in women from taking statins is 0. You might reduce your risks of heart disease if you look at the bias studies, because these studies, I got 1 minute and let me give that answer properly. These studies are done in about 300 to 400 clinical centers. The data is gathered predominantly by the pharmaceutical industry. The endpoints of myocardial infarction as well as softer endpoints are very hard to show the most robust endpoint is mortality. I don't even want to talk about cardiovascular mortality. I only want to talk about mortality. So when you look at these trials, they are so biased by pharmaceutical industry that I'm not sure. I try to take my patients off of statins. And I think that one of these days I'm going to have a lawsuit against me from the statin industry, and I'm going to have an Ali fund that you all are going to fund so that I can defend myself. Thank you.